So this webinar today is our Managed Care Rest of State Refresher. So we're going to bring folks up to date a little bit on what's going to happen with the Rest of State implementation and walk through stuff. So we've got some housekeeping things to start. So really, ideally, this is our Rest of State Refresher. There won't be that much new information today except for some of our training going forward and those kinds of issues, but we are really going to try to package kind of the things you need to keep the biggest eye on, as well as share some of the lessons learned that we figured out from downstate as well. So a couple housekeeping issues before we dive in. You can use the chat functionality for Q&A, so please, as we go on, type your questions into the chat box, not the Q&A box, but the chat box. We're going to keep a running list of questions about the webinar today, and we will answer as many of them as we can at the end. Other questions we will also take back and get those questions answered and be able to get back to folks later. Additionally, the slides are already posted on mictac.org. So if you want a copy of the slides, you can actually go to our website right now, although I don't recommend doing it during the webinar, and download a copy of the slides for yourself. And then the webinar will be available shortly, probably the next couple days. Will be up on our website if you have others who weren't able to join today. And also just a reminder, the information that we present today and the timelines that we present today are as current as of today. So if they were to change tomorrow, then obviously they would be different. But there is some flexibility in terms of timelines and those kinds of things. Just the agenda today, we're going to talk briefly about what MCTAC is. We're going to talk about the contracting, credentialing, and billing timeline, talk a little bit about contracting and credentialing generally, the billing and claims testing and the importance of that, utilization management and authorizations, adult behavioral health HCBS, the RPC process. We're going to talk a little bit about upcoming events, tools, the readiness assessment, and Q&A. Obviously, with this many items on the agenda, we are hitting this at a very high level today, and this is really to lay the context for what will be much more detailed training and technical assistance going forward. And so the goal is just to reorient folks to what we've done so far, what's available to folks, the changes that we know are coming, and to get folks ready for the more intensive TA that's coming their way very shortly. So at its most basic level, the Managed Care Technical Assistance Center, or MCTAC, is here and funded by the state to really help all mental health and substance use agencies make the transition to managed care. We've been working with the whole state for about 1.5 years now and have reached, I don't know, somewhere around 20,000 people in that time. And so we're really excited about that, but our goal is really to work with all providers around the state. And we really have two very core partners, the McSilver Institute for Poverty Policy and Research here at NYU, and CASA, the National Center for Substance Use Addiction, which is CASA's in the process of rebranding at the moment. We also have a number of partners, including CCSI, NIAFRS, ICL, and IDEAS. So we want to talk a little bit about the contracting, credentialing, and billing timelines. And what we're going to present here today, and we've pulled together this nice little graphic. Some of this aligns very well with our training, but this also aligns with the way you as an organization should be thinking about how you're going to approach this process. So really, we want folks to be thinking about contracting and credentialing happening in February, March, and April. And with plans, this is really a two-step process. They all do it a little bit differently. Some of them do the credentialing process first, and then they do the contracting process. Some do the contracting process, and then they do the credentialing process. But really, right now, in February, March, and April, you should be moving your organization through the contracting and credentialing process with the idea that that will be done at no later than the end of April. We are, and we'll talk about dates and stuff at the end of this. We've scheduled a number of contracting fairs around the state for folks to meet the managed care plans if they haven't already, but we strongly recommend that you be working through that process now. The reason that it's so critical to wrap up the contracting and credentialing process, around no later than April, is that in order to do claims testing, which is critically important for being successful in the transition to managed care, you have to have the contracting and credentialing process finished. the plans are not going to be doing claims testing with agencies that they haven't contracted with, right? So they're going to do claims testing with their network. So if you're not done with your contracting process, you're not part of their network, and therefore they won't be reaching out to you to do claims testing. Claims testing is really going to help make sure your system is ready to bill managed care when this goes live. So the idea is you do the contracting process, and then you do the claims testing process starting in April, May, and June. And that by the end of May and June, you have done claims testing around all your different program types with all of the plans that you have contracted with. Some of the things that people have gotten in trouble in is they've done claims testing with one program type, but they didn't do claims testing with pros, for example. Well, so maybe the clinic works, you've been billing that plan for clinics for a long time, but the pros billing or the OTP billing is a whole different process. And so, it's going to be really, really critical to do claims testing around each individual program type and also in a real claims environment, not sending an Excel spreadsheet with the fields in it, but really trying to bounce it up through your clearinghouse if you have one, down to the plan, and having them bounce it back. That is the way to do it, because you may find problems in your system. We've found that people find problems in their own system. They also find some issues with their clearinghouse, and then there's also plan issues. So really, all three of those chunks have to be addressed. The other thing I will say is that, one, this webinar today about rest of state really applies to adults. There'll be a similar process that we're engaged in with kids, which a lot of information is going on right now. And also, the HCBS timeline is different from this, and HCBS Services will start in October, and we'll talk about that in a little bit at the end. All right, then once you get to July, you're engaged in no longer what would be called claims testing, but actual billing for services. So the goal is that this is all wrapped up, so by July 1st, you have identified the vast majority of problems that you're going to run into in the billing process. Now, we are not going to pretend that there won't be additional problems once it goes live, but the goal is to minimize that. One of the kind of cautions that we've seen in rest of state, in downstate, is that people waited on the contracting end, and so they weren't able to do claims testing before go live, and so the problems they encountered were in live, let's call it live testing or actual billing and claiming process, and not so much in the claims testing process. So I've covered most of what's on this slide, but I strongly recommend people, this is a good slide to download and use as a reference. So, so a couple things that I hadn't talked about real quick just to highlight from this slide as well is that if you have a existing contract with a plan for clinic services or something else, you may only need to execute an amendment to that contract, but you should work closely with the plan to find out exactly what that amendment should look like. If you don't have a contract with a particular plan, you're going to need to execute an entire contracting and credentialing process with them. So you may only need to do an amendment if you already have a contract, but you still need to reach out to them. It's not all set up. And then second, if you don't have any contract with them, that you will need to do the entire contracting and credentialing process. A couple state protections that are built into this process, just to highlight for folks. Nothing has changed, but just to remind folks of these things. If the plan has 5 or more enrollees within any of your particular program types, they have to contract with you. So, for example, if pros, you have 5 members in your pros program from Fidelis, Fidelis is required by the state to contract with you. The vast majority of the time, and also so the state, they'll have to contract with you. So for the vast majority of plans, they're going to have to contract with everybody. And so they're going to be reaching out to you and you're going to be reaching out to them. But it's very important to return those phone calls and start that process quickly. The second piece is payment requirements. They have to pay the government rate, the current APG rates that you currently receive for your fee-for-service clients. They have to pay those rates for the first 24 months starting on July 1st. So really the contracting process is not going to be about rate negotiations. It's simply about setting up the credentialing process, setting up the contracting process, and those kinds of things. So really there is no reason not to engage the contracting process with any plan. In terms of TA, and we've already announced this, it's on our website, we'll go to it in a little more depth later, we are doing a pretty intensive process of contracting webinars to really help folks with the idea of, what are the things they need to focus on in the contracting process in more depth. And then we're doing contracting fairs around the state. So we will be coming to your region soon to do a contracting fairs, and all the dates are on our website and have been announced and will be out shortly. Okay, and we have a slide on it at the end that we'll go through specifically. Billings and claims testing. I hit most of this stuff, but obviously everybody is really, really strongly encouraged to engage in claims testing with every single plan that they have a contract with for every single program that they will be billing. One of the things that a large group of providers found after we went live was that for one of their program types, there was a glitch in their EHR which wouldn't allow them to bill all the plans. That is an issue that you want to discover now and not discover once you're doing live billing. So it's important that you engage in the full claims testing process throughout. And I think the state would back us up on this. If there's one thing that everybody should do besides contracting before we go live, is to make sure that claims testing is in place. You should also refer to the billing manual, our billing guidance, as well as the billing manual from all of the plans, as well as the OMH and OASIS billing manuals. And then we will be doing very, very detailed billing training on a field-by-field basis around, what is the setup for the claiming process for each plan. And we've worked collectively with the plans in the city on that. We're working with all the plans upstate on that. And it really eliminates much of the confusion about what the billing process looks like as well. So I strongly encourage you when that comes out to do that. Okay. So utilization management and authorizations. As of July 1, some services will require authorizations, and we will be doing a detailed presentation on a service-by-service, plan-by-plan look at what requires authorization, what doesn't require authorization, et cetera. So we strongly encourage folks to come and participate in that training. In addition to that, for new clients, there will be different rules at the beginning on July 1 than there are for existing clients. So there will be a 90-day grace period for authorization for existing clients, and we'll get into the details of that when we do the training. And then we will, just to highlight again, I know I've said this 3 times, but we will be coming to a region near you to do in-person training, really walking people through the utilization management process, step-by-step, plan-by-plan, service-by-service. Okay. With that, I'm going to turn this over to my colleague, Boris O'Lord, who's going to walk us through HCBS.
All right. Good afternoon, everybody. So quickly, as Andy mentioned before, the timelines for HCBS are, shifted basically by 3 months. It is expected that the assessments for HCBS Services will start in July 1st of 2016, and that the services themselves will go live on October 1st. There'll be many components of the technical assistance that will be coming either in person or web-based, providing on HCBS, which will include things like e-PACES and what's referred to as H codes, which is a definition of HARF eligibility and HCBS eligibility through e-PACES, documentation training, meaning what does a provider need to have in their chart to document services, plans, and so forth. Billing that's specific to HCBS rules about billing. Service overview training, a very in-depth discussion about what do the services look like, mean, and how potentially you can think about providing them. The workflow, meaning how does somebody go from being HARP identified to getting HCBS services, and the entire workflow that takes them through the inter-eye assessment, through the care plan, to the referral process, and so forth. And the plan of care that's conducted by the health home or care coordinator will be provided as well in the template of that plan of care. So again, since the HCBS services are shifted by 3 months or so from July 1st, those timelines of those trainings will be announced, and we'll be coming out to do that as well. One of the things that part of the managed care transition is implementation of regional planning consortiums, and so which involves the local mental health hygiene directors and other stakeholders in part of the consortiums. And they're going to be beginning and staffing, excuse me, those consortiums soon. It's, again, as I mentioned, multi-stakeholder groups that includes consumers, families, LGUs, managed care companies and HARPs, adult and children's services, the housing providers, hospitals, and so forth. Of course, the state agencies, and you can see the list here of all the types of stakeholders that are going to be part of this. And it's based on the premise of transforming the behavioral health system and how the implementation impacts the system and the people and the families served. Requires, of course, a collaboration between community focus and continuous vigilant attention. This is the role and function of the RTC. So there'll be more information on the RTC and how you can get involved and when it's going to be meeting and so forth. But we wanted to make sure that the folks on the phone were aware that that is one of the groups that's being formed, and more information will be forthcoming. The upcoming events that Andy and I referred to, and again, I think some of these have been already announced, some have not, maybe have officially been announced or registration's not available. So one is the next webinar that we're going to do is on 2/10, and that's the contracting webinar. It's an overview. Following on 2/17, there'll be a follow-up on the timelines and state protection of contracting. Again, a more in-depth discussion on contracting. And then, as Andy mentioned, an in-person contracting fairs. And the dates are here for Buffalo, Syracuse, Albany, Long Island. We're still working on Lake Placid, North Country, and Hudson Valley. And we're hoping to have them in April and March. As soon as we have the dates and places, we'll make sure that everybody gets the announcement and is able to register. We hope you attend. And there'll be more information on those in-person contracting fairs. We have conducted one in New York City. It was very well attended. All the managed care companies attended, and it was well received by all. But in no means you should wait until these contracting fairs to start your contracting process. You should definitely start this sooner. What the contracting fairs offer one is you actually get to meet the individuals, which sometimes you only get to talk to. Two is if you're in the process and you're having problems, it gives you an opportunity to have those face-to-face discussions with the managed care companies, and also introduce your agencies and what you do and who you are to the managed care companies in person, and so they can better understand who you are as well. The April month and May will be followed by the billing presentations, as Andy mentioned, and we'll have more information on those, and those are going to be very detailed presentations on utilization management, authorization, and billing requirements and so forth. So we'll be doing those in person. Tools. So as a reminder, we want to make sure folks are aware of the tools that are available on the MidTech website. We have the Managed Care Matrix, which is currently being updated to include the rest of the state managed care companies and information. The Matrix is an interactive tool meant to provide information, not just contact information, even though that's one of the main purposes of the Matrix, is to provide managed care information, but also other types of information about the managed care company. The billing claims document is online. That's the one we've done in New York City. We don't expect much, if any, changes to the rest of state. This is the document we'll be reviewing in the in-person presentation in April. We also have the glossary of terms in case you're confused on what means or HARP or anything like that. We have that online as well. We have our utilization management tool that was used again for New York City presentation. So if you want to get a little bit of a jump start, but we'll be doing those trainings and in person more again together with the billing in April. We're working on the credentialing and the charge master tool. Those tools are not available yet, but those are forthcoming. And as we develop them, we'll make sure everybody's aware of it. This is just, the next slide is just to give you a sense of how the matrix looks online right now. Only the New York City area is highlighted where you can click on it, and I'll give you the information. As we populate the rest of the state, of course, all the counties and all the regions will be accessible as well. And here, if I can just turn it over back to Andy for readiness assessment.
Okay. So many of you have already completed our readiness assessment because we rolled this out actually more than a year ago now, and we've had 546 of them come back, both from OMH, OASAS, and OCFS agencies. The goal here is really to assess your readiness for the transition to managed care. So we are going to be sending out in the next day, the next week, an email to all the agencies in the state, so everyone on this phone call. The readiness assessment, again, as an agency, if you have completed it before but you've made progress and you've been working on this for a while and you want to complete it again to get a sense of where you are now, feel free to complete it again. If you've never heard of this before or you didn't complete it the last time, we strongly encourage you to complete the readiness assessment. It really does walk through, and I'll skip to the next slide, a whole host of domains that really look at all the different areas that you'll need to focus on for this transition to managed care. So it looks at areas of contracting and communication and authorizations and IT and level of care, quality and finance and access and evaluation. It really does cut across all of these areas, and this is kind of a consensus document that's been reviewed by providers and the plans and trade associations and the state. So it really represents not just our view, but really a consensus view of the areas that people need to look at. So by completing the readiness assessment, not only do you get a sense, and it's really a step-by-step guide of all the things you need to think about as an agency to do this, but in addition to that, you're also going to get an individualized report back of exactly where your agency stands in the level of readiness. So a 1 on this, it's a 1 to 5 scale in these items. So a 1 is I have no idea what's going on and I really need a lot of help, all the way to 5, which is we have everything under control and we know exactly what we're doing. There have been very few 5s. But I will say that you get back this individualized report that not only lists your score, but also compares you to the benchmark score of the rest of the state, so you get a sense of how you compare to others. I will also say that your information, if you share it with us with a readiness assessment, goes nowhere else other than here. It doesn't get, your individual information does not get shared with the state. It does not get shared with other providers. It doesn't get shared with your local governing unit. It stays here. We will share benchmark, global information with all of those folks, and we do that here in terms of how we give the global score. But we do not share any individual agency's information with everybody. This is your information. We also recommend that when you complete the readiness assessment, that you do not do it as an individual. Don't send it to the person in your agency who fills out surveys. You really should sit down with a team at your agency that's going to tackle this transition to managed care. We strongly, if we could recommend nothing else, that you develop a team at your agency that's going to work on this. The team should be made up of the folks responsible for finance and IT and quality and clinical and quality assurance. That group of people should be working to get the agency ready for managed care. And we've noticed that the agencies that are most successful in this transition so far are also those that, one, have a team, but also have somebody whose job it is to really help with this transition. That may not be that person's only job, but that they have been designated by the agency to really lead this transition to managed care. It's critically important. But we also recommend that when you complete the readiness assessment, that team complete the assessment, that it not be done just by one person. So with that, I am going to stop with the formal part of this presentation. We have about half an hour left. I don't know if we'll use that entire time, but we have about half an hour left, and we're going to open this up for questions. So we have been writing these questions down so far. So we're going to take about a minute pause. We strongly encourage folks to chat questions into the chat box as they have them. and then we are going to go through as many questions as possible. So we are going to do that. So if you just give us one minute to get organized here, and then we'll start going down through the list of questions. But I encourage folks to start chatting the questions in as we go. Okay, the first question is, can you clarify how we should begin contracting when we do not know yet what approved plans are in rest of state? Actually, the rest of state plan conditional designation list is out. Yeah, and I believe it is on the OMH and OASAS websites already, but we'll double check that and get back to folks. The second question gets back to that, and when we get that list, we will also blast it out to the whole rest of the state so everybody has it. Okay, so when will all the carved-in behavioral health service rates be available for rest of state? The rates will be exactly what the rates are now. There's rate protection for 2 years, so whatever the rate is now will continue for rest of state when we go live in July. The next question, we just answered that. Okay, so here we go. So the question about our matrix. The goal for our matrix to go live with rest of state is, I'm looking at the other folks in the office. So yeah,
end of the month.
So we're looking to have the matrix go live for rest of state around the end of this month. It might float by a week or two, but you know, end of February, beginning of March, we're looking to have the matrix live and updated for rest of state. So by then you'll have the contact information and all that other kind of stuff. Okay, so there was a question actually from a plan around mental health and substance use disorder providers showing some reluctance to contract. I think all of our TAs are really going to be focused on really emphasizing the importance of contracting with the plans for all the covered services, because otherwise, you know, folks won't be able to really be active and successful in this process. Okay, I'm just going to say there are a number of health home questions which have come in, not related to HCBS, and we will not be answering the kind of more general health home questions on this webinar. I really encourage people to talk to their lead health homes and also work through their representatives at DOH on that. Yeah, go ahead.
So just to jump in back to the question of or the comment from the plan, one of the, and we'll get in more into details when we do some of the more detailed contracting announcements for people to realize that if individual providers do not contract with the plan, when go live happens on July 1st, for that provider to get paid, they might be required to do what's called single case agreements or other types of agreements for particular individuals. Within those plans, it becomes really complicated quickly. So again, you know, I think there's a lot of encouragement and emphasis for providers to contract. Of course, you know, it has to make sense and be appropriate, you know, for the provider. But again, we would strongly recommend that providers do everything possible to contract with the plans.
There was a question around recipients receiving education on this transition. In New York City, the local DOHMH, so LGU in New York City, did some of that training, and I know that certainly at a state level there's some movement towards making sure that there's some training for recipients as well in this transition, and also a number of providers have done a lot of work with their individual recipients, and there's a local government unit. So just the LGU, sorry, I was using the acronym, a local government unit. There's another question here about a standard authorization form, and is there one? There is not a standard authorization form, and I would not anticipate that prior to go live that there will be one. Each plan is going to be having their own kind of authorization process. That process is relative, and we'll do this in the UM training, that process is relatively standardized in terms of when authorization required and when it isn't required, but in terms of the exact authorization forms and paperwork and that kind of stuff, that is not standardized at this point. Okay, so we will be providing some questions about HCBS, and we'll be providing more information specifically on the timelines for HCBS, as well as the assessment process and the workflow process as well. We left out a notation for a UM and billing training in Long Island, so thank you for a number of people for noting that. We will add that in. It is not because we had forgotten it and we weren't planning on doing a UM and billing training in Long Island, which of course we will do. We just had not included in the slide, so thank you for noting that for us. Sorry, I'm just going through a number of questions. Hold on one second. Okay, so the question came in about how you get involved with their RPCs. I strongly recommend you reach out to your local field offices as well as the county in your counties in your region that you serve, and discuss with them getting in contact to be part of the RPCs. And we'll, as we have more information on that, we will we'll be diving in on that as well. Yes. So somebody asked what services this applies to. So this applies to PROS and ACT and ART. So basically, it applies to pretty much all Medicaid services at this point, with the exception of housing, with the exception of mental health housing, and yeah, with the exception of mental health housing, it applies to our all carved out behavioral health services. And we'll go through them in detail as we do the UM stuff. So the implementation date for managed care for rest of state has not been delayed. So there is some confusion. So implementation for managed care in rest of state is going live on July 1. The HCBS implementation is going live on October 1. So that was the delay. But the actual regular managed care role carve-in is happening on July 1 in rest of state. Okay. How do you know who you should contract with? That's a really important question. So I think one of the takeaways from this webinar that you can go back and look is to go back into ePaces, and if you go back into ePaces and look where your clients are. Look at the plans that your clients are a member of for their physical health care if they're carved out, and where you have the greatest percentage of clients who are part of a managed care plan. That's where I would start. But basically, you're going to want to contract with all the plans for whom you have clients with. But you know, you're obviously going to want to start with the ones you have more. And I think one of the really good takeaways to start with is actually to go back and do that. Another question is there a standard contract that all MCOs will be using? No. Most of the contract language is relatively standard, and when we do our contracting training and the contracting webinars in the next week or two, we'll walk through the areas of the contracts that may be different and things you're going to want to focus on. I'll just highlight again, because we've got a number of questions in this area, that the rates are staying the same and will be maintained for 2 years after carve-in. Okay. So how will Article 31 mental health clinics be interfaced with this? Yeah, so all Article 31 mental health clinics are carved in as of July 1. Many of you, through your Article 31s, have been dealing with managed care for 20 years. But if you still have clients who are fee-for-service, they're going to be carved in with some very rare exceptions, including duals, Medicaid and Medicare recipients, and a couple other stuff. That's all on our website. But the vast majority of clients will be carved in if they weren't already to managed care for Article 31 mental health clinics. Where you can get a printout of today's slides. The slides are actually already up on our website at mictac.org. If you go on there, on our website, you can find the slides and download them. So there will be assigned, so there's a question here about HCBS rates. HCBS rates have been identified by the state, and the rates, at least initially, with the plans for HCBS services will be set at a state level. Okay, so there's a question about what provisions should or should not be part of a contract with an MCO. I would look back to our contracting guidance that's coming out in the next couple weeks. we'll walk through a lot of that with you. So the County Director of Managed Care Plans has a number of terms on it, COMM or MCAID or CHP. So somebody asked what those terms mean. So COMM is commercial, MCAID is Medicaid, and CHP is Child Health Plus. And if you go to our glossary on our website at mctac.org, all of those terms are laid out. So if you have any questions about any acronyms, and I'm sure we've used a number of acronyms today which are unfamiliar to many people, those acronyms are included in our website. Okay. Should we be contracting for HCBS at the same time as current services? The likelihood is no. That will likely be a separate amendment to your contract for HCBS Services, and it may happen a little bit later than the initial contract for your state plan services. And we'll have more information on that as we roll out specific HCBS training. Okay. This is a really good question came in about, one of the things that folks have heard is that, oftentimes people change managed care plans. And how are people going to be able to deal with that? And so I think that the common answer is that most agencies who have multiple managed care plans that they deal with have set up a system through their electronic health record where they check e-PACEs. On a relatively regular basis, and usually have a standardized system where they check once a week or once a month or whatever for all their clients to make sure, one, they're still in Medicaid, and two, where their assignment is for plans. Okay. There's some questions around HCBS assessment and billing for those HCBS assessments, and we'll deal with that later as we get closer to that. When will providers get a list of their HARP-eligible clients? What will happen on that is you won't get an exact list, but very shortly you'll be able to start to check e-PACEs. And in our previous trainings, and we'll do this again, there's a whole list of the codes for HARP eligibility. They're called H codes for HARP eligibility, HARP enrollment, those kinds of things. And you'll be actually able to look at those H codes for your individual clients and see whether they're either HARP eligible or HARP enrolled, and also eventually whether they're HCBS enrolled as well. Do you know if OASAS will release a model contract for providers? No, there's not at this time a plan to release a model contract for the transition to managed care. That doesn't just apply to OASAS, it applies to OMH as well. Housing at this point for mental health housing is not carved into managed care and will be excluded. The individuals living in the mental health, OMH, mental health housing, with the exception of the state hospital system, will be carved into managed care unless they're duals. So, there's a question about when the enrollment letters will start to go out for rest of state. We're not sure exactly what the date is, but we'll take that back. If we are currently billing under managed care, will there be any differences?
If it's I assume it's for Article 31 clinics, there shouldn't be any differences, but if they are, when we do our billing presentation, those will be noted.
Okay. So around contracting for HCBS services, we'll have more information on that going forward as we get a little closer to go live. If you're a housing provider, should you begin to develop relationships with the managed care companies in the area you serve? Yes, you won't be contracting with them yet, but you're going to be a vital resource for them as they move forward. So there's absolutely, and there is also the possibility that at some point it might be, some of the housing services might be carved in. So yes, so it is a very good idea to start to build those relationships now. So somebody asked about HCBS services. Will they need to contract with managed care companies? The answer is yes, and there'll be more information available. Another question came in, are duals, so people who are dually eligible for Medicaid and Medicare, going to be part of the carve-in? And the answer to that is no. Duals are going to continue to be carved out, so you will continue to bill fee-for-service Medicaid for your clients who are duals, unless in the very rare exception they're enrolled in a FIDA, and that's a whole separate process. So somebody asked, is our contracting, coding, and billing push forward a quarter for HCBS providers? And while not exact, I think that's probably a good assertion there, so absolutely. So someone asked a very critical question about what type of wine goes better with chicken, and I have no comment on that. I think it's a personal preference issue. White. Somebody's saying white in the background, but we have to inject a little humor into our presentation.
And thank you for that question.
Yes, and thank you for that question. It is really a critical question. And while someone here said white, I prefer a lighter red with my chicken. So, but I will leave that to the audience. Okay, so there's a presentation about whether there will be presentations for board members. And we've developed some slides that can be used for board members, I believe, that are on our website at this point. And we also, what I actually think is probably the best use, we've gotten pretty sophisticated, a pretty brief slide deck on Managed Care 101. What are the kind of the basics of this that we've offered a couple times and we will be offering again, I believe, around the state. And I think that webinar and that slide deck is probably a really good place to go to look for something to give to board members.
You know, and so the other piece, just to, of course, it's important to educate the board and make sure the board is aware of it, but also as a reminder that all staff in your agency should be aware of this transition and be educated. So whatever information you might be using for the board, please don't forget to consider to spread that information or parts of that to the rest of your staff. One of the lessons learned in New York City was we had folks attend a lot of technical assistance trainings, but the information didn't always make it down to the manager level, supervisors, or even line staff, and it's also important that they are aware of what's going on.
Yeah, and I would also note that certainly that MCO 101 can serve as a kind of a grounding thing that everybody needs to know. But I would also be really thoughtful about what are the particular pieces of information that particular parts of your agency need to know. So our mailing list is broad, but when we do billing training, that's information that all of your billing staff and all of your finance staff are really going to need to know. So be thoughtful about who needs to know what, and if you're the person who goes to the training, and be thoughtful about what pieces of information from that training you need to pass on when you get back, and who it is most helpful to pass that information on to. Okay. So there's a question, you know, we obviously are stressing for the providers to be reaching out to plans, and there was a question here on the opposite side of that is, are we stressing with the plans to be reaching out to providers? Our experience in New York City is the plans were really actually very proactive in trying to make sure they contracted with all the providers they're supposed to. It's a requirement for them to contract with all providers who have 5 or more clients, and they were very proactive in that. One thing I would emphasize, and we experience this issue as well, is that, you know, we don't always have the best contact information for who we're supposed to contact in any particular agency, and I think that probably applies to many of the plans as well. So they have a contact information for somebody at the agency, but they may not have the right person. So one of the things that's an educational standpoint is to make sure that your staff know that if somebody from one of the plans contacts them about contracting, that they should make sure that information gets to the right person, even if they're not the right person, and to expect those calls. We've had plans reach out to us a couple times and say, you know, with a particular agency, we've been trying to reach out to them on contracting. The person who picks up the phone doesn't seem to know what that's about, and we keep getting stuck. Can you help us? So I would just, you know, information point for folks is particularly at the program director level and above, to make sure that your staff know if they get a reach out from one of the plans looking around contracting information, they want to let whoever the appropriate person at the agency is know. But we have, I just want to emphasize, the plans have actually been pretty proactive about that, and that's been our experience in the city. Okay, as both an OMH and OASAS provider, will you have separate contracts with the plans? No. You will have one contract with the plans, and that contract will identify all the services that you offer. So you would have, you'd have an Article 32 substance use clinic line on that contract and Article 31 mental health clinic line on that contract, but you would not have a separate contract. Can managed care companies decline contracting with agencies? If so, why? And I'm going to speak about state plan services. For state plan services, if you have more than 5 clients in 5 or more clients in any particular program type in your agency, the plan is required to contract with you. If you only have 1, then they don't. For the first 2 years. That will change after the first 2 years, and exactly how that change hasn't been determined yet. But so in general, the plans have to contract with you. We have not experienced, and I don't even know if we've experienced this once, where we've heard from a provider who said they were trying to contract with a plan for a particular state plan service, and the plan was saying no. In general, the plans have been trying to get the widest, most broad network possible, and with the 5-client rule, it's pretty much made that pretty standard. So, I think that's really important. Okay, so there's another question here. Doug on our webinar yesterday about HCBS Services indicated that a survey had been sent out to providers around what services they were providing. This is only for HCBS. That's an issue around some providers got designated for particular services and now have decided they either want to delay their start process or decide they don't want to participate in a particular service. That was a city-specific issue. If that issue comes up again upstate, it's likely that they'll send out that survey again. But if you're in Buffalo, for example, there's no reason for you to worry about that at this point. Okay, we have reached the end of our question list. I'm going to ask Jocelyn to add in any other questions or folks to chat in any additional questions that come in right now, and we'll give folks another minute or so to do that before we wrap up. All right, so I don't see any more questions coming into our question list. So I just want to take the opportunity to thank all of you for joining us today. We're really excited to get up to all the various different parts of the state. And I know we've met many of you already, but to meet you again and also to be able to provide really much more specific training than we were able to provide when we've come up to the different parts of the state before. So I want to thank all of you for taking the time to do that. We have had a couple additional trainings. So there's a question around being a downstate care management agent, a downstream care management agency for health homes and contracting. I would really refer back to your lead health home on that. We've explicitly not been doing stuff around those contracting issues for health homes. It's not part of one of the work that we do. So I really encourage you for health home related questions to go back to your lead health home and have those conversations there. Okay. All right. I think with that, that we're going to wrap it up there. So I want to thank everybody again for taking the time to join us today. And as you have additional questions, please feel free to email them to us at mixtech.info@nyu.edu. My brain froze up for a second as well. And there are also on our website and on OMH and OASAS's website specific question boxes to address issues as they come up. So I also strongly recommend that folks take advantage of that as well. So with that, we will wrap up, and thanks for taking the hour to be with us today. And we look forward to seeing you in person soon, wherever you may be.